We will begin in 5 or so minutes. Good afternoon, all. We'll start in a couple minutes. Good afternoon, everyone, and thank you for joining MHPA today for our Webinar Wednesday series. Before we get started, I would like to remind all of our attendees that today's webinar is in listen-only mode. If you have any questions throughout the webinar, you can click on the Q&A button down at the bottom of your Zoom window and ask any questions there. We'll collect them, and at the end, we'll address the questions. Our presenters will address those one by one, and then you can also connect with our presenters afterwards if we don't have time. The slides will be made available via PDF to all registrants, as well as a video recording via our YouTube account. I would like to welcome and thank Melanie Ritchie and Corey Collins from MHPA's bronze partner, Centauri Health Services, for leading today's webinar. With provider office closures due to the global pandemic, telehealth has emerged as a means of ensuring necessary care continues to be provided to members. NCQA has aligned HEDIS measurement year 2020 measure specifications with this change in healthcare delivery. This presentation will review updates to HEDIS measures for measurement year 2020 with a focus on telehealth visits and the importance of capturing this data, as well as exclusions demonstrate your HEDIS performance. We'll also review strategies to mitigate the potentially negative impact of COVID-19 on your measurement year 2020 HEDIS rates. And with that, I'm excited to turn things over to Melanie and Corey.
Good morning. My name is Corey Collins. I'm a delivery owner of the HEDIS quality product at Centauri. So basically that means I'm responsible for everything around IT in our quality product. I really appreciate everyone attending this morning, and I'm presenting with my clinical operations partner, Melanie Ritchie, who I will now hand it off to.
Thanks, Corey. So I'm Melanie Ritchie, Vice President of Clinical Solutions, and as Corey said, I'm his operational partner for quality solutions. I've worked with health plan and vendor HEDIS and quality programs since 1995, and I have a team of product owners, project managers, as well as analysts that support our clients as well as the internal team. With that, I will go ahead and start. As Patrick had mentioned, our key discussion points today are looking at the measurement year 2020, specification changes that are related to COVID-19, steps to ensure that telehealth visits are captured and why that's important, ways to ensure that members are getting necessary care while navigating the limitations created by the pandemic, and then we'll also talk through the impact of exclusions on measure rates. So NCQA has aligned with CMS and other stakeholders to support the increased use of telehealth as a result of the COVID-19 pandemic. They've updated telehealth guidance for 40 measures to include guidance on how telehealth can be used for the denominator, the numerator, and exclusions. They've also included and identified the type of telehealth that's allowed for measures. And there are several different types. So you have synchronous visits, which require real-time interactive audio and video telecommunications. If a measure specification doesn't specifically call out telehealth categories, it includes synchronous telehealth. And this is because telehealth is built using standard CPT and HCPCS codes for professional services in conjunction with a telehealth modifier and/or a telehealth place of service code. Therefore, the CPT or HCPCS code in the value set will meet criteria regardless of whether a telehealth modifier or place of service code is present. Measure specifications will also indicate when synchronous telehealth is not eligible for use and should be excluded from that measure. Telephone visits, a measure will generally indicate when telephone visits are eligible for use by referencing the telephone visits value set. And then finally, asynchronous visits. These may be referred to as an e-visit or virtual check-in. It's not in real time, but it still requires two-way interaction between the member and the provider. For example, asynchronous telehealth can occur using a patient portal, secure text messaging, or email. A measure will generally indicate when asynchronous telehealth visits are eligible for use by referencing the online assessments value set. As I'm sure you've seen, there are many ways telehealth is used by medical professionals, as well as many ways that it's accessed by patients. Telehealth can be used as part of an integrated approach to disease management with a mix of in-person and virtual visits. It's also used by urgent care for triage purposes, and it's used in different ways by hospitals for post-hospital discharge follow-up. As a result of these different ways of using telehealth, as well as the increased use of it during the COVID-19 pandemic, the Task Force on Telehealth Policy was formed. The task force was charged with developing consensus recommendations to mitigate risk, maximize benefits of telehealth, ensure quality was maintained, as well as there was accessibility and efficacy. And then they've also been tasked to look at strategies to fully integrate telehealth into the healthcare ecosystem. These recommendations were formed by over 300 written public comments, as well as a virtual town hall that was attended by almost 1,000 stakeholders. The consensus of the task force was to keep most of the COVID policy changes as well as to explore new ways to leverage telehealth. To fully develop their recommendations, the task force formed 3 subgroups: patient safety and integrity, data flow and care coordination, and finally, impact on total cost of care. The top findings from the task force were that telehealth is healthcare's natural evolution into the digital age. I think we've all seen this over the last decade where this has just been more accepted. Telehealth and telemedicine is a critical tool in advancing a well-coordinated, patient-centered, value-optimized health system. And finally, flexibilities that occurred during the height of the pandemic generated new evidence and adaptations that question our previous restrictions for telemedicine when the technology was less mature and there were more limited use cases to things like rural areas. In addition to the top findings of the task force, I wanted to share some key discussion points from each of the subgroups. From the patient safety subgroup, they saw telehealth as an opportunity to enhance patient safety by preventing care delays, reducing exposure to pathogens, and minimizing travel for in-person care, especially for at-risk populations. The program integrity group, some of their concerns with expansion of telehealth were around fraud, waste, and abuse. There is emerging artificial intelligence to audit claims and other data that will make it easier to detect issues related to fraud, waste, and abuse. And there's also an opportunity to assess IP addresses and digital signatures to make it really easy to identify those bad actors. From a quality perspective, since telehealth is a care setting and not a modality, it should be held to the same standards as in-person care when possible and appropriate, modifying quality measures only when necessary. Measure stewards like NCQA should avoid altering the standards and expected outcomes for telehealth versus in-person care. There may be an opportunity to have additional rules and protocols for data sharing and care coordination between telehealth and other care settings, but I think that's one of those more to come concepts. And then from a cost of care perspective, early evidence suggests that expansion of telehealth has helped to reduce costs through reduction in missed appointments. And as we all know, as patients are attending their appointments, they're much more likely to adhere to the care plan that's been developed for them. And along with that, you'll see improvement in disease management metrics. We're also seeing increased use of transitional care management services to improve outcomes and reduce admissions. And there are instances of skilled nursing facilities which have leveraged telehealth to resolve resident health issues, which would normally have resulted to a trip to the emergency department, which again is a cost reduction for that facility. As we mentioned earlier, NCQA has updated 40 measures to align with the increased use of telehealth. We've broken out the telehealth impact to the measures by denominator, numerator, and exclusions. The one thing I do want to point out is the 3 new measures: cardiac rehab, kidney health evaluation for diabetics, and osteoporosis screening in older women already include telehealth within the specifications. You'll notice that the telehealth changes go across the continuum of care and address the effectiveness of care, access and availability, utilization and risk-adjusted utilization, as well as the ECDS measure domains. So it is fairly comprehensive. We won't go into each of the measures, but mainly wanted you to have this information as you look at how your organization has changed its policy for the use of telehealth and where you may need to make additional changes to support your HEDIS project and ensure you maximize data to accurately reflect the care provided to your members. And this slide is just showing all of the measures where telehealth was added to the denominator or eligible population for the measure. The next slide is the measures where telehealth has been added to the numerator for compliance purposes. And then finally, these measures either had the telehealth exclusion removed or had telehealth added to the advanced illness exclusion. I will go ahead now and just turn this over to Corey to review capturing the telehealth visits.
Thank you, Melanie. So, as Melanie just discussed, telehealth is an increasingly common healthcare setting. So the question becomes, as a health plan, how do you capture those telehealth visits? And are there any restrictions to using telehealth? And if so, in what situations? So to begin with, there are 3 types of telehealth services. They are Medicare type telehealth visits, virtual check-ins, and e-visits. So Medicare type telehealth visits include visits with a provider that use real-time telecommunication systems between the provider and the patient. So this is the synchronous telehealth that Melanie mentioned earlier. So on this slide, we've noted several common telehealth services CPT codes for office/outpatient visits and consultations. We also provided a list of all the codes for telehealth visits in the slide. So these codes and types of visits were previously limited to established patients. However, per section 1135, of the Social Security Act, there's a temporary waiver of CMS requirements for participation in CMS programs and an allowance for reimbursement to providers who, acting in good faith, provide care during an emergency. This also includes a waiver of the requirement for a patient to be an existing patient to utilize this type of telehealth. This waiver is limited to the duration of the health emergency or 60 days from the date of the waiver, unless extended. And that current waiver was retroactively declared from March 1st, 2020. So the second type of telehealth visit is a virtual check-in. So this is a brief visit. It can be telephonic or a remote evaluation of a recorded video or images submitted by an established patient. It can be synchronous or asynchronous, but it must be with an established patient. So finally, e-visits are generally asynchronous and must be an established patient as well. We have provided the codes for virtual check-ins and e-visits in the slide as well. Let's go on to the next slide, please. So now we'll be discussing how to capture those telehealth visits so that your measured performance reflects that care. So as the title of this slide mentions, if you don't have a claim, your HEDIS vendor can't consider the visit. So these are some of the recommendations that we make to our HEDIS clients. First, you want to ensure that your telehealth vendors and network providers are submitting claims for every telehealth visit and that they're using the codes listed in that previous slide. Similarly, you should review the types of visits and limitations with your in-network providers and telehealth vendors. Also, if you delegate claims payment to any entities, those entities should be following those same coding practices that we just discussed. Further, for pharmacy claims, you should ensure that the pharmacy and the prescriber's MPI is captured. This is required for opioid measures like UOP. So per that measure spec, if you don't have an MPI, every opioid prescription is treated as a new and different prescriber and or pharmacy, which could cause your measured performance to decline. So now that we've discussed how to capture telehealth visits proactively, what can you do to retroactively capture potentially missing telehealth visits? So for our HEDIS clients, we recommend partnering with your pharmacy benefit manager, your IT team, and your telehealth vendors. The reason for that is some ways you can capture potentially missing telehealth visits include querying your pharmacy claims for new prescriptions that don't have a corresponding provider visit, querying your lab results for new tests that don't have a matching provider claim for the test. And finally, potentially query your telehealth scheduling systems to find where there's completed visits that don't have a corresponding claim. So I'll go on to the next slide. So now that we've discussed what telehealth is and how to capture those visits, I'd like to discuss how you can ensure your members are maximizing their available telehealth benefits. So at Centauri, we've been particularly concerned about access to telehealth for low-income members. You know, all this technology is great, but if the member doesn't have internet and internet-enabled devices accessible, you know, they're not going to be able to leverage the care. So some recommendations we make include establishing Wi-Fi hotspots in your parking lot, kind of similar to how they do schools, so that your members who don't have home internet access can leverage your Wi-Fi to securely access telehealth. Another option is providing burner phones in exchange for the members utilizing telehealth via that provided phone, or lending smartphones or even tablets to at-risk members, and also advising members on how they can securely access public Wi-Fi for telehealth utilization. Some other options you could consider include leveraging your call center to outreach to members and providers to educate them on telehealth availability and the rules around telehealth that we just discussed, as well as written and digital communication campaigns to educate members that the telehealth is available, as well as to educate your providers on those claim coding best practices. And next slide, please. So in my final slide, I'd like to discuss some Measure Year 2020 changes. We'll begin with exclusions and how you can best leverage them. So there are two main types of exclusions: required exclusions and lifetime exclusions. So lifetime exclusions mean if the event occurred at any point in the member's lifetime, that member is excluded from the measure. Now, required exclusions, they have a shorter time frame generally, but they do mandate that the member be excluded if they meet the criteria. So some challenges with these exclusions and opportunities. With lifetime exclusions, you'll need a method to capture lifetime exclusions. For instance, a mastectomy, cervical cancer, or immune system disorder that occurred prior to the member's eligibility with your health plan. So oftentimes, you know, the evidence of those events, like I said, occurred prior to the member actually being enrolled. So we advise plans to leverage medical records and/or lab data to find these, because frequently you can find that evidence even without a standard medical claim. So around required exclusions, so required exclusions can improve your measure performance, but they do have their own unique challenges. So for instance, some required exclusions require data from certain types of claims, although the measure doesn't require the member to have that benefit with you. So for instance, the PSA measure has an exclusion that requires evidence of prostate issues and a prescription of 5-alpha reductase inhibitors. However, the measure doesn't require the member to have a pharmacy benefit with you. So that's another scenario where you can use medical records and/or lab data to identify members who meet that criteria. So another area where you may have to consider non-standard claim data is around look-back periods for negative comorbid condition history. So for instance, the CWP measure looks back 12 months. But if your membership is relatively volatile, you may not have claim history for that member's 12 months prior. So again, medical records, lab data can be very, very valuable. So, you know, as if 2020 wasn't bad enough, we are predicting that some measures such as ADD are going to see some market changes due to the high percentage of people who are remotely working and attending school. So for instance, you may see an increase in ADD measure denominator, as well as a decrease in compliance for substance abuse measures. So, you know, just some things you can do to counteract that is proactive communication to members newly prescribed ADD medicine, as well as outreaching to any at-risk members. So another 2020 change is around updates to Appendix 3. Specifically, certain types of providers are now accepted as behavioral health providers. So this includes, and forgive the lengthy wording, it's not mine. So this includes provider assistants, certified community mental health centers, or comparable terms used within the state in which it is located, and certified community behavioral health clinics. So Appendix 3 has information on what types of providers qualify to be those community health. So the action item around this is ensuring that your provider mapping, specifically specialties, is updated to reflect this change. Another change is around the PPC measure. So NCQA revised the definitions of last enrollment segment. We do expect this change will benefit plans because the specific change is that last year, the specifications didn't clearly state that a member would have continuous enrollment if they had a minor change, like a name change, or there was a benefit plan change. So with measure year 2020, it's now clarified that minor changes such as those do not break continuous enrollment. So finally, there's been changes around denominator eligibility. Several measures, in fact, have refined denominator eligibility rules. For instance, CWP now only requires the member to be enrolled for 30 days prior and 3 days after the event. And likewise, the SPC and SPD measures removed the restrictions which formerly limited the consideration to only one telehealth visit in the year prior to the measure year and one in the measure year. So the net effect of both of those is that it's now easier for members to be in those denominators. And that is the end of my slide. So thank you.
Okay, thank you very much. And we do have some questions, but before I start with those, I do want to remind our attendees that you can, there's still time to use the Q&A feature down at the bottom, that button. Please feel free to use that, or the chat as well. That works too. We'll go ahead and address those questions. But we have a few right now, and let's get started. What were some of the areas where the telehealth task force didn't have consensus?
Patrick, this is Melanie. That was related to behavioral health substance abuse. There were some current concerns about prescribing those telephonically and not really seeing follow-up. So I think there's more to come just in terms of how that will be addressed going forward.
Okay, very good. What recommendations are you providing to your clients regarding telehealth?
So we're recommending clients to evaluate opportunities to expand telehealth and to reimburse providers for that care. So they also need to ensure that the providers are submitting claims using the appropriate codes and telehealth modifiers, which is provided on the slide. We also recommend promoting telehealth with members as an alternative to in-person care. This, as well as just getting needed care, it also supports the development of the patient-provider relationship. And finally, as a part of this, we recommend assessing your members' ability to participate in telehealth, particularly access to Wi-Fi and internet-enabled devices. And you may need to assess whether the plan should provide technology to those members as a supplemental benefit if they don't otherwise have access.
Very good. What role does value-based care, or P4P, play in the expansion of telehealth?
So VBC and I always struggle with that, P4P, So those provide an opportunity for shared costs between providers and plans, meaning the provider's reimbursement is tied to the quality of the care that they provide. So you may want to monitor the use of telehealth as a part of your VBC program, not only to track utilization, but also to track the outcomes of that care. So as well, appropriate reimbursement for telehealth also allows patients to leverage that care, as well as it encourages providers to offer it.
Very good. We did have some questions regarding the presentation recording and the slides. I want to remind our attendees that the slides will be emailed to you in PDF form, and the recording of this webinar will be on MHPA's YouTube account. And that said, we did have some questions on how best to contact you, Corey and Melanie. Do you have a slide with your contact information, or if not, we'll make sure we get that to our attendees? Do you have a preferred email, perhaps?
The emails in the chat that's good for me.
Okay, fantastic. Again, attendees will be getting the slides, the contact information, and the recording if you have any additional questions. With that said, I'm going to give everybody back about a half hour. Thank you so much for attending, and we look forward to seeing you on our next webinar. Thank you all. Have a great afternoon. And thank you, Corey and Melanie.
Thank you. Thank you. It's a pleasure.
Bye-bye.